Hi, this is Dr. Akhtar Amin. Today topic is dry eye. Dry eye occurs when there is inadequate tear volume or inadequate tear function, which result in unstable tear film and ocular surface disease. Dry eye is extremely common condition and is particularly common in post-menopausal women and also in the elderly population. There are certain related diseases. So the first is dry eye disease. It is a multifactorial disease of the ocular surface and tear film. Dry eye disease is accompanied by increased osmolarity of the tear film, and there is inflammation of the ocular surface. And there is keratoconjunctivitis sicca. KCS refers to any eye with some degree of dryness. Xerophthalmia. It describes a dry eye associated with vitamin A deficiency. Xerosis refers to extreme ocular dryness and keratinization that occurs in eyes with severe conjunctival cicatrization. Sjogren syndrome, autoimmune inflammatory disease of which dry eye is a feature. Now the physiology of the tear film. The tear film consists of three layers: lipid, aqueous and mucus. The lipid layer, it is on the top, secreted by meibomian glands. The meibomian glands secrete lipid layer. The meibomian glands are found in the lid margin. Then aqueous layer, secreted by the lacrimal glands. And the last one is mucus layer, secreted principally by conjunctival goblet cells. The constituents are complex, with as many as 100 distinct proteins identified. The spread of tear film. The tear film is mechanically distributed over the ocular surface through a neuronally controlled blinking mechanism. Three factors are required for effective resurfacing of the tear film. Number 1, normal blink reflex. Number 2, contact between the external ocular surface and the eyelids, and the third one is normal corneal epithelium. Now, functions of tear film. The first one is lipid layer. The lipid layer is the outer one. The outer lipid layer is composed of polar phase containing phospholipids adjacent to the aqueous mucin phase, and a non-polar phase contain waxes, cholesterol ester and triglyceride. The polar lipids are bound to lipocalins within the aqueous layer. These are small secreted proteins that have the ability to bind hydrophobic molecule and may also contribute to tear viscosity. Lid movement during blinking is important in releasing lipids from glands. The thickness of the layer can be increased by forced blinking and conversely reduced by infrequent blinking. The function of lipid layer to prevent evaporation of the aqueous layer and maintain tear film thickness, to act as a surfactant allowing spread of the tear film, and deficiency results in evaporative dry eye. The next is aqueous layer. The aqueous layer secretion. The main lacrimal glands produce about 95% of the aqueous component of the tears, and the accessory lacrimal gland of Kras and Wolfram produce the remainder 5%. Secretion of the tears has basic resting and much greater reflex components. The reflex components occurs in response to corneal and conjunctival sensory stimulation. tear breakup and ocular inflammation and is mediated via the fifth cranial nerve. It is reduced by topical anesthesia and falls during sleep. Secretion can increase 500% in response to injury. Composition of the aqueous layer. It contains water, electrolytes, dissolved mucins, proteins, growth factors derived from the lacrimal gland, the production of which increases in response to injury, pro-inflammatory interleukin cytokines that accumulate during sleep when tear production is reduced. Function of aqueous layer: to provide atmospheric oxygen to the corneal epithelium, antibacterial activity due to proteins such as IgA, lysozyme, and lactoferrin, to wash away debris and noxious stimuli and facilitate the transport of leukocytes after injury, to optically enhance the corneal surface by abolishing minute irregularities. The last one is mucus layer. Composition: mucins are high molecular weight glycoproteins that may be transmembrane or secretory in type. Secretory mucins are further classified as gel forming or soluble. They are produced mainly by conjunctival goblet cells but also by the lacrimal glands. The superficial epithelial cells of the cornea and conjunctiva produce transmembrane mucin that form their glycocalyx, which is extracellular coating. Staining of diseased epithelium with rose bengal indicate that the transmembrane and gel mucus layer are absent and the cell surface exposed. Damage to the epithelial cells will prevent normal tear film adherence. Now, the function of mucus layer: to permit wetting by converting the corneal epithelium from a hydrophobic to a hydrophilic surface. Lubrication. The mucus layer, and another function is lubrication. Deficiency of the mucus layer may be a feature of both aqueous deficiency and evaporative states. Goblet cell loss occurs with cicatrizing conjunctivitis, vitamin A deficiency, chemical burns, and toxicity from medications. Now, the regulation of tear film components. It is controlled via hormones and neuronal control. The hormonal control. Androgens are the prime hormones responsible for regulation of lipid production. Androgens. Estrogen and progesterone receptor in the conjunctiva and the lacrimal glands are essential for the normal function of these tissues. The neural control. Neural via fibers adjacent to the lacrimal glands and goblet cells that stimulate aqueous and mucus secretion. Mechanism of dry eye disease. The four core interrelated mechanisms thought to be responsible for the manifestation of dry eye. They are tear instability, tear hyperosmolarity, inflammation, and ocular surface damage. Inflammation in the conjunctiva and accessory glands as well as ocular surface is present in 80% of patients with KCS and may both a cause and consequence of dry eye, amplifying and perpetuating disease. The presence of inflammation is the rationale for specific anti-inflammatory measures such as steroid therapy. There is a strong association between dry eye syndrome and reduced level of systemic androsterone sulfate and epiandrosterone sulfate. Now the classification. The classification of dry eye usually applied is that of the 2007 International Dry Eye Workshop DEWS, with a basic division into aqueous deficient and evaporative types. Most individuals have considerable overlap between mechanisms. So both aqueous deficiency and evaporation, they overlap in most individuals. And it is important to be aware during patient assessment of the likely presence of multiple contributory factors. So the first one is aqueous deficient. It is divided into Sjogren syndrome. It may be primary or secondary, and non-Sjogren dry eye, which is further divided into lacrimal deficiency. Lacrimal deficiency may be primary, for example, age-related dry eye, congenital alacrimia, familial dysautonomia, or it may be secondary, for example, inflammatory and neoplastic lacrimal gland infiltration, acquired immune deficiency syndromes, graft versus host disease, lacrimal gland or nerve ablation. And there is lacrimal gland duct obstruction. Lacrimal gland duct obstruction occurs in trachoma. In other diseases like cicatricial pemphigoid, chemical injury, Stevens-Johnson syndrome. Another type of non-Sjogren dry eye is reflex hyposecretion. It may be sensory, for example, contact lens wear, diabetes, refractive surgery, neurotropic keratitis, or it may be motor block, for example, 7th cranial nerve damage or systemic drugs. The next type is evaporative. Evaporative may be intrinsic or extrinsic. The intrinsic may be due to meibomian gland deficiency, for example, posterior blepharitis, rosacea. It may be due to disorders of the lid aperture, for example, due to the excessive scleral show, lid retraction, proptosis, facial nerve palsy. So this is disorders of lid aperture. Evaporative may also be due to low blink rate, for example, in Parkinson disease, prolonged computer monitor use, reading, watching television. In the intrinsic causes drug action, for example, antihistamines, beta blockers, antispasmodics, and diuretics. So the next type of evaporative is extrinsic. It may be due to vitamin A deficiency, topical drugs, including the effects of preservative, contact lens wears, and ocular surface disease such as allergic conjunctivitis. So whether a patient has primary aqueous deficiency or evaporative dry eye, the end result is ocular surface inflammation and discomfort. There is also effect of environmental factors, as well as the basic classification. Reduce draws attention to the effect of environment on the type of dry eye with which a patient presents. This can be both internal, such as age, hormonal status, behavior patterns, and external, such as exacerbation of evaporative factors in an atmosphere with low relative humidity. One of the important causes is Sjogren syndrome. Sjogren syndrome SS. It is an autoimmune disorder. It is characterized by lymphocytic inflammation and destruction of the lacrimal and salivary glands and other exocrine organs. The classic clinical triad consists of dry eyes, dry mouth, and parotid gland enlargement. But other features are common and can affect all organ systems. The condition is classified as primary and secondary. Primary when it exists in isolation, and secondary when associated with another disease, commonly rheumatoid arthritis or systemic lupus erythematosus. Primary affect females more frequently than male. Although in clinical practice the diagnosis may be made on less stringent grounds, the American College of Rheumatology criteria for diagnosis specify in patients with a clinical picture suggestive of Sjogren's syndrome. There are 3 points. The first one is positivity for anti-SSA and anti-SSP antibodies or positive rheumatoid factor together with significant positive anti-nuclear antibody. Ocular surface staining above a certain grade, focal lymphocytic sialadenitis to a specified extent on salivary gland biopsy. So widely used, but older American European consensus group criteria are more extensive and include more clinical findings but give result consistent with the ACR criteria. Treatment options for Steven-Johnson include a range of symptomatic treatment for dry eye, as we will discuss after a short time, dry mouth and other manifestations, salivary stimulants, for example oral pilocarpine, and some cases immunosuppression and biological blockers such as rituximab. Clinical features. The most common ocular symptoms are feelings of dryness, grittiness, burning, characteristically worsen over the course of the day, stringy discharge, transient blurring of vision, redness, crusting of the lids, lack of emotional or reflex tearing. This is unusual. Symptoms of KCS are frequently exacerbated on exposure to condition associated with increased tear evaporation, for example air conditioning, wind and central heating, or prolonged reading or video display unit use when blink frequency is reduced. So the symptoms associated with keratoconjunctivitis sicca are exacerbated by exposure to wind, air conditioning and central heating. Signs. There will be posterior seborrheic blepharitis with meibomian gland dysfunction. In conjunctiva, there will be redness, staining, keratinization, conjunctivochalasis. The staining will be with rose bengal and lesamine green. Keratinization, conjunctivochalasis is a common response to exacerbating factor for the chronic irritation of dry eye, such that a self-sustaining cycle is maintained. It is also commonly occur in the other ocular surface diseases. Tear film. In the normal eye, as tear film breaks down, the mucin layer becomes contaminated with lipid but is washed away. So in the normal eye, as the tear film breaks down, the mucin layer becomes contaminated with lipid but is washed away. In the dry eye, the lipid contaminated mucin accumulates in the tear film as particles and debris that move with each blink. The marginal tear meniscus strip is a crude measure of the volume of aqueous in the tear film. In the normal eye, the meniscus is 0.2-0.4 mm in height, but in dry eye become thin in less than 0.25 mm, or it may be absent. In the cornea, there is punctate epithelial erosions that stain well with fluorescein. Filaments consist of strands of mucus and debris such as shed epithelial cells. These are the filaments. They are typically attached at one end to the corneal surface. The filaments stain well with rose bengal but less so with fluorescein. Mucus plaques with similar constituent may occur in severe dry eye. They consist of semi-transparent white to grey, often slightly elevated lesions of varying size. The complications can be vision threatening and include epithelial breakdown, melting, perforation and occasionally bacterial keratitis. So these are the complications. Can be vision threatening and include epithelial breakdown, melting, perforation and occasionally bacterial keratitis. Investigation. The aim of investigation is to confirm and quantify a clinical diagnosis of dry eye. Although the symptoms in a given patient do not change, objective science can fluctuate. The correlation between symptoms and test is poor. However, the reliability of test improves as the severity of dry eye increases. The test measures the following parameters: stability of the tear film as related to its breakup time, tear production, Schirmer test, fluorescein clearance, and tear osmolarity, ocular surface disease, corneal stains, and impression cytology. There is no clinical test that allows the diagnosis of evaporative dry eye to be definitely confirmed. It is therefore a presumptive diagnosis based on the presence of associated clinical finding. It is suggested that the tests are performed in the following order because the Schirmer strip paper can damage the ocular surface and cause staining. There is a poor correlation between symptoms and clinical tests in patients with dry eye syndrome. However, the reliability of test improves as the severity increases. The first test is tear film breakup time. The tear film breakup time is defined. It is abnormal in aqueous tear deficiency and meibomian gland disorders. It is measured as follows. Fluorescein 2% or an impregnated fluorescein strip moistened with non-preservative saline is instilled into the lower fornix. The patient is asked to blink several times. The tear film is examined at the slit lamp with a broad beam using cobalt blue filter. After an interval, black spots or lines appear in the fluorescein stain film, indicating the formation of dry eyes. The breakup time is the interval between the last blink and the appearance of the first randomly distributed dry spot. A breakup time of less than 10 seconds is suspicious. Development of dry spot always in the same location may indicate a local corneal surface abnormality, for example epithelial basement membrane disease, rather than intrinsic instability of the tear film. Next, the Schirmer test is done. Schirmer test is a useful assessment of aqueous tear production. The test involves measuring the amount of wetting of a special filter paper known as number 41 Whatman. So the test involves measuring the amount of wetting of Whatman filter paper, 5 mm wide and 35 mm long. It is 5 mm wide and 35 mm long. The test can be performed with or without topical anesthesia. In theory, when performed with an anesthetic, it is Schirmer 2. Basic secretion is measured, and if it is done without anesthetic, it is called Schirmer 1. Schirmer 1 measures maximum basic plus reflex secretion. In practice, however, topical anesthesia cannot abolish all sensory and psychological stimuli for reflex secretion. The test is performed as follows. Excessive tears are delicately tried. So first, the excessive tears are delicately dried. If topical anesthesia is applied, the excess should be removed from the inferior fornix with filter paper. Then the filter paper is folded 5 mm from one end and inserted at the junction of the middle and outer third of the lower lid. Middle and outer third of the lower lid. Taking care not to touch the cornea or lashes, the patient is asked to keep the eyes gently closed. After 5 minutes, the filter paper is removed and the amount of wetting from the fold is measured. Less than 10 mm of wetting after 5 minutes without anesthesia or less than 6 mm with anesthesia is considered abnormal. Less than 10 mm without anesthesia, less than 6 mm with anesthesia. Results can be variable and a single Schirmer test should not be used as a sole criteria for diagnosing dry eye, while repeatedly abnormal tests are highly supportive. Ocular surface staining. There are several staining methods like fluorescein, rose bangle, Lesamine green. Fluorescein stained corneal and conjunctival epithelium where there is sufficient damage to allow the dye to enter the tissues. The rose bangle is a dye that has an affinity for dead or devitalized epithelial cells that have lost or altered mucus layer. Corneal filaments and plaques are also shown up more clearly by the dye, and the use of a red-free filter may help visualization. 1% solution of rose bangle or a moisture impregnated strip can be used. The dye may cause intense stinging that can last for up to a day. Particularly in patients with severe KCS, to minimize irritation, a very small drop should be used immediately, preceded by a drop of topical anesthetic, and the excess washed out with saline. The Lesamine green stain in a similar fashion to rose bangle but cause less irritation and may be preferred. This is a Lesamine green. The pattern of staining may aid diagnosis. Interpalpebral staining of the cornea and conjunctiva is common in aqueous tear deficiency. Superior conjunctival stain may indicate superior limbic keratoconjunctivitis. Inferior corneal and conjunctival stain is often present in patients with blepharitis or exposure. In dry eye syndrome, Lesamine green solution is preferable to 1% rose bangle, as it stains in a similar fashion but causes less irritation. The other investigations, they are rarely performed. They are fluorescein clearance test and tear function index. May be assessed by placing 5 microliter of fluorescein on the ocular surface and measuring the residual dye in a Schirmer strip placed on the lower lateral lid margin at set interval. Delayed clearance is observed in all dry eye states. Other rare tests are tear film osmolarity. Measurement techniques are available and emerging as an accurate means of diagnosis. A threshold value that distinguishes between a healthy eye and an eye with dry eye syndrome varies from 305 millismol per liter and 316, depending on the degree of tear film instability. A widely accepted threshold is 308, and a value of 316 appears to discriminate between mild and moderate severe dry eye. Tear osmolarity may not correlate with ocular symptoms, but it does not correlate with effective treatment when evaluated in long term. Another test is tear constituent measurement. Tear sample can be assayed for the presence of markers known to be elevated. For example, matrix metalloproteinase 9 or decreased lactoferrin in dry eye. Another test is phenol red thread test. Uses a thread impregnated with a pH sensitive dye. The end of the thread is placed over the lower lid. The length weighted the dye change from yellow to red in tears is measured after 15 seconds. So the length weighted is measured after 15 seconds. A value of 6 mm is abnormal compared to the Schirmer test, but takes less time to perform. Tear meniscometry is a technique to quantify the height and thus the volume of the lower lid meniscus. Impression cytology can determine goblet cell numbers. Treatment strategy. The underlying causative process of a dry eye are generally not reversible. The management is therefore structured around the control of symptoms and the prevention of surface damage. DIUs have produced guidelines based on the earlier International Task Force guideline for dry eye, in which suggested treatment options depend on the level of severity of disease. Severity is graded from grade 1 to 4. The DIUs guideline can also be applied in a graded approach, proceeding to the next level if the preceding measures are inadequate. So the first level, the level 1 is treatment is education and environmentally dietary modification. Establishment of realistic expectations and emphasis on the importance of compliance. Lifestyle review include importance of blinking, well studying, watching television, using a computer screen which should be oriented below eye level to minimize palpebral aperture size, and the management of the contact lens wear. Environmental review, for example, increased humidity may be possible for some environments. Installation aids for the eye drops manufacturer supplied are makeshift, such as nut crackers or to hold plastic bottles. Should be educated for patient with reduced dexterity, rheumatoid arthritis. Caution the patient that laser refractive surgery can exacerbate dry eye. Systemic medication review to exclude contributory effects and eliminate offending agent. Discontinuation of toxic, preserve topical medication if possible. Artificial tear substitute including gels and ointments. So the artificial tear substitutes including gels, ointments, which we will discuss. Use of preserved drops should fall within level 1, and categorize non-preserved drops as a level 2 bucket. Mucolytic agents may be specifically indicated for some patients. Eyelid therapy, basic measures such as warm, compress, lid hygiene for blepharitis, reparative lid surgery, entropion, ectropion, excessive lid laxity, scleral show, nocturnal leg ophthalmos, by tapping the lids at bedtime, wearing swimming goggles during sleep, extreme cases by lateral torsorrhapy. Now the level 2, there should be tear substitute should be non-preserved. Anti-inflammatory agents. The anti-inflammatory agents are topical steroids, oral omega fatty acid, other agents such as topical cyclosporine, tetracycline, or mebumyanitis and rosacea, punctal plugs, secretagogue, for example, pilocarpines, civimilin, ribamipide, moisture chamber spectacle and spectacle side shields. So this is level 2 treatment. For level 3, serum eye drops, autologous or umbilical cord serum, contact lenses, and permanent punctal occlusion. For level 4, systemic anti-inflammatory or surgery such as eyelid surgery, torsorrhapy, salivary gland autotransplantation, mucous membrane or amniotic membrane transplantation for corneal complications. Now let's talk about tear substitute. They have a relatively simple formulation that cannot approximate the complex components and structure of the normal tear film. Their delivery is also periodic rather than continuous. Almost all are based on the replacement of the aqueous phase of the tear film. There are no mucus substitute, and paraffin is only an approximation to the action of tear lipid. Optimal frequency of installation varies with agent and with severity. Number of drops and gels. A large range of preparations is available. One agent or category of preparation has not demonstrated Superiority in particular agents are often preferred by individual patient with limited rationale. There are different types. Number one type is cellulose derivatives. Cellulose derivatives are heteroamylose and methyl cellulose. They are appropriate for mild cases. Another type is carbomer gel. Adhere to the ocular surface, so are longer lasting, but some patients are troubled by slight flaring. Other agents include polyvinyl alcohol. They increase persistence of the tear film. They are useful in the mucin deficiency, sodium hyaluronate, povidone, glycerin, propylene glycol, polysorbate, and others. Dicofosol is a newer agent, works as a topical secretagogue. Next are the tear substitutes or ointments. Contain petroleum, paraffin, mineral oil, used at bedtime to supplement daytime drops. Or gel instillation. Daytime use is precluded by mark blurring. Some practitioners do not prescribe these for long-term use. Next is eyelid spray. Applied to closed eye, typically contain liposome-based agent, stabilize the tear film and reduce evaporation. Next is artificial tear insert. Implaced once or twice daily, offer extended duration treatment, are prepared by some patients. Next is mucolytic agents. Stylcysteine 5% drops, useful in patients with corneal filaments and mucus plaques. Stylcysteine dissolve may cause stinging or installation. Stylcysteine is malodorous with limited shelf life. Manual debridement of filaments may also be useful. Next are preservatives. Can be a potent source of toxicity, especially after punctal occlusion. Numerous non-preserved drops are now available, including some multi-dose products. In general, should be used in preference to preservative containing preparation in any more than mild disease or with installation more than 3 to 4 times daily. Possible, preservative-free formulation should be used for dry eye patient when other topical medication is required. For example, in the treatment of glaucoma, newer preservatives such as polyquat and purite seem to exhibit lower ocular surface toxicity than older agents such as benzalkonium fluoride. Next year's substitute is hemoderivative. Treatment has been used to manage severe ocular surface disease including graft versus host related dry eye, Sjogren post-LASIK dry eye, persistent epithelial defects, recurrent erosions. Now about the punctal occlusion. Punctal occlusion reduces drainage and thereby preserve natural tear and prolong the effect of artificial tear. It is of greatest value in patients with moderate severe KCS who have not responded to frequent installation of topical agent. Punctal occlusion may be temporary or reversible and permanent. Temporary occlusion can be achieved by inserting collagen plugs into the canaliculi. So collagen plugs are used. These dissolve over a number of weeks. Main aim is to ensure that evipora does not occur following permanent occlusion. Initially, in the inferior puncta are occluded and the patient is reviewed after 1 to 2 weeks. If the patient is now asymptomatic and without evipora, the plugs can be removed and the inferior canaliculi is permanently occluded. In severe cases, both the inferior and superior canaliculi can be plugged. Reversible prolonged occlusion can be achieved with silicone or long-lasting, long-acting 2 to 6 months collagen plugs. So, for reversible silicone and collagen plugs. Problems include extrusion, granuloma formation, distal migration. Plugs that pass into the horizontal portion of the canaliculus cannot be visualized, and although they can usually be flushed out with saline. If they cause evipora, this is not always possible. The surgical retrieval may be needed. Next is permanent plugs. Permanent occlusion should be undertaken only in patients with severe dry eye who have had a positive response to temporary plugs without evipora. It should be avoided in patients, especially if young. who may have reversible pathology. All four puncta should not be occluded at the same time. Permanent occlusion is performed following punctal dilatation by coagulation. By coagulating the proximal canaliculus with cautery. Following successful occlusion, it is important to watch for signs of recanalization. Laser cautery seem to be less consistently effective than surgical thermal coagulation. Now let's talk about the anti-inflammatory agents. There are topical steroids. Generally low intensity preparations such as fluoromethanol are effective supplementary treatment for acute exacerbation. The risk of longer term treatment must be balanced against the potential benefit in each case. The next anti-inflammatory are omega fatty acid supplement. Omega-3 fish oil, flax seed oil have dramatic effect on symptoms, facilitate reduction of topical medication. Next anti-inflammatory are oral tetracycline for extended course, 3 months at relatively low dose, may control blepharitis, pneumonitis, reduce tear levels of inflammatory mediator. Doxycycline may prepare to minocycline on the ground of adverse effect profile. Topical cyclosporine, usually 0.05%, reduce T cell mediated inflammation of lacrimal tissue, resulting in an increase in the number of goblet cells and reversal of squamous metaplasia of the conjunctiva. Other options for treatment are contact lenses. Although contact lens wear can exacerbate dry eye, particularly due to inflammatory, sensory, and evaporative effects, the symptoms can be outweighed by the reservoir effect of fluid trapped behind the lens. In addition, contact lenses are effective at relieving symptoms resulting from a secondary corneal changes. However, patients should be cautioned that there is increased risk of bacterial keratitis. Several manufacturers have developed contact lenses specifically designed to reduce dry eye discomfort during lens wear. The material used silicone hydrogel retain moisture for 12 to 16 hours. So this silicone hydrogel, retain moisture for 12 to 16 hours. Are single-use daily disposable, occlusive gas permeable scleral contact lenses. They provide a reservoir of saline over the cornea, are occasionally used in patients with extreme dry eye and exposure. Silicone rubber lenses which were used in the past are no longer available. Other options are optimization of environmental humidity, reduction of room temperature to minimize evaporation of tears. Room humidifiers may be tried but are frequently disappointing because much apparatus is incapable of significantly increasing the relative humidity of an average size room. A temporary local increase in humidity can be achieved with moist chamber goggles, side shield to glasses. May be cosmetically unacceptable. Miscellaneous options are botulinum toxin injection to the orbicularis muscle, help control blepharospasm that often occurs in severe dry eye. Injected at the medial canthus, it can also reduce tear drainage, presumably by limiting lid movement. Other miscellaneous options are oral cholinergic agonists such as pilocarpine 5 mg 4 times daily. Sevimilin may reduce the symptom of dry eye, dry mouth, and Sjogren syndrome. Adverse effect: blur vision, sweating. Let's mark with Sevimilin. Another option is submandibular gland transplantation for extreme dry eye. Extensive surgery is required to reduce excessive level of mucus in the tear film. Last option is serum autologous blood eye drops. Autologous are umbilical cord serum 20 to 100%. The blood component remaining after clotting has produced subjective and objective improvement in studies in patients with dry eye, may aid in the healing of persistent epithelial defects. However, their production and storage are associated with practical challenges. Finger prick autologous blood is a low cost, readily accessible, practical treatment that appear to be safe and effective. Thank you very much.